Good evening, everyone. Welcome to First Aid AMC Clinical free 2-week sessions again. So tonight we're going to do something different than others. So tonight we're going to start a medicine topic. You guys have learned few things already by this time. So just to recapitulate what we have been doing for the last week. So you had a initial session with us that was in December where we discussed about the AMC clinical exam. We did some introduction, how to start your preparation, what this exam is going to look like, and what an examiner expects from you. So we had a very good discussion on that session, right? Then after that, from January 7th, we started these free 2-week sessions. And as part of these free sessions, you are getting to know about the course. You're understanding how is the structure of this class, and also if it's going to help you or not, right? So we always offer these free sessions to everyone to get to know about first aid and understand why our students pass the exam, just like the standard of the course and the passing rate of the course is so significant than any other course in Australia. I just want you to have a look at it. I want all of you to see that is there any difference that you can find out from any other courses that you have done. So that is the real meaning of sharing everything that we do in our course to everyone completely free. So these 2 weeks free sessions are meant to be designed in this way so that you can understand a bit of psychiatry, a bit of random role play sessions, and a bit of medicine. So the structure of these 2 weeks free sessions are in this way so that you understand every classes that we are going to take is going to be similar like this. So tonight we are starting cardiology. There are 3 sessions that you will get to finish cardiology with me in this free class. And I'm sure you are going to understand a lot about this AMC clinical preparation. First aid AMC clinical, we are the first in Australia who has made the clustered wise approach in AMC clinical. There was never ever this much cluster wise approach. People used to memorize all the cages. People used to memorize 300 400 cages, which was really difficult. We are the first people who made it into a cluster, and now everyone is using them. So now also you also need to know that every batch that we take courses, we make sure that we update our notes in a way that it reflects the standard of the Australian health system, and we make sure that you know the updated guidelines. If you see the notes that we are giving you in your course, and if any of you have done the course, let's say 3 years ago or 2 years ago, you will see there is a huge amount of difference between the notes that we are giving you now and 2 years ago. So we make sure that we update things, make sure you get updated guidelines, and we follow the therapeutic guideline as the main guideline for AMC clinical. So any management, anything that you are going to learn from us, it's going to reflect therapeutic guidelines. That's mainly what we follow in Australia as a doctor. And also you can definitely take help from John Murtag or RSCGP if you need any particular information. But as I said, that course note will be more than enough to start your preparation and finish your preparation. You don't need to know anything else. We will make sure that all the classes that you're going to have in these 5 months will be more than enough to pass this exam if you can do what we say. Okay, so let's start cardio. When we do a medicine cluster, we want you to understand how to build a structure for medicine cages. The structure is very important. That's what we follow. We don't need to memorize everything. We need to have a structure in our mind, which we can follow for all cages. So in the history task, definitely we will greet with the patient. You will introduce yourself with the patient. If the patient is in a lot of pain, patient has any kind of complaint, we always try to reassure the patient that we're going to take care of the patient, right? So reassurance, very important. If there is something acute, like acute chest pain, acute headache, acute shortness of breath, we make sure patient is vitally stable before we start asking any further history. So what are these vitals that we look for? We look for what's the patient's blood pressure, pulse, respiratory rate, temperature, and oxygen saturation. So we always make sure to ask this to the examiner before we go for any other questions from the patient. Then we go to the history of presenting complaint, which is the HOPC. You will always find, I always say HOPC. What is the HOPC? Is the history of presenting complaint. History of presenting complaint is what is the actual complaint for this patient. A 50-year-old comes with sudden onset chest pain. That's the chest pain is the HOPC in that case. So we always start with the main complaint and we ask detail about it. Once that is done, then we start moving on to some differential diagnosis. There is nothing more important than knowing differential diagnosis in these cases. As many as possible, you should know the differential diagnosis for each of the cluster that we are doing. Okay? So there is no hard and fast rule that you have to do you have to ask 3 or 4 differential, nothing like that. As many as the time permits, but definitely has to be relevant differential. Like if someone having a chest pain, and if we are focusing mainly on their abdominal pain or if they're having diarrhea or not, that's not that relevant. For a chest pain patient, diarrhea, not the first thing that I would be asking for. For a chest pain patient, shortness of breath, if the patient has got any palpitation, if the patient has got any kind of sweating, nausea, vomiting, right? Or if the patient has got dizziness, lightheadedness, those will be my first thing that I would be thinking of, not diarrhea. So relevant questions are always important. Don't think that if you just ask every question that you can possibly ask, that's going to give you a good mark in exam. Never. You have to always make sure that the questions you are asking are relevant to that particular case. After we finish differential diagnosis, we always finish every case with these 3 things: SADMA, past medical history, and family history. SADMA, you all know already, we did it in psychiatry: smoking, alcohol, any medications. This 3 is the main one. Recreational drugs, then activities, those are not very important. Or allergies, not allergies sometimes we ask, especially if we are going to start any medication for the patient, we ask allergies as well. But recreational drugs, not very important for medicine related cases. So smoking, alcohol, medication, allergies. So that's the history format. First, you introduce yourself, reassure the patient, make sure patient is vitally stable in acute cases, ask the HOPC in detail, go to the differential diagnosis, finish with SADMA, past medical and family history. That's the format you should always have in your mind when you are taking history from a patient, not just in exam, in your real life, especially when you will start becoming a doctor in Australia and you will see patients here, you always follow this format and you will find out that how easy it becomes to see a patient in real life using this kind of format. Now, after history, most of the time the task will be ask physical examination finding from examiner. What is this physical examination finding from examiner? This is not about doing physical examination or performing physical examination on a patient. This is about asking physical examination finding from examiner, and whatever you are asking, examiner will give you finding related to that. If you don't ask something, you will not be given that. So the physical examination from examiner. So after you finish the history, you thank the patient, then you turn towards the examiner, and then you ask the examiner these questions. So examiners, so you normally we say that, dear examiner, I would like to do physical examination on my patient on general appearance. So first we start with general appearance. So is my patient comfortable or in distress? I would like to know the vitals. So vitals, you can ask two at a time. So I would like to know the vitals, blood pressure, pulse rate, please. And then other three you can ask at a time. Then examiner will say blood pressure 120 over 30, pulse rate 110. Then you ask, I would also like to know temperature, respiratory rate, and oxygen saturation, please. Examiner will give you those findings. After that, we do a general examination, which mainly focus on pickled. Pickled is a mnemonic for pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema, and dehydration. We don't ask all of them to every case, always the relevant one. For a chest pain, what's relevant, guys? If a patient has chest pain and you're doing a physical examination, out of this, what are the important things that we need to ask?
Pallor, cyanosis,
Yeah. Anything else?
edema.
clubbing,
Edema. Yes. Yes, that's right. So these three are the most important ones. So definitely we need to know the pallor because it could be angina due to anemia. We need to know cyanosis. That's important. And also edema is important as well. Okay. After that, we go to the main system. We always start with the main system. So if a patient is having a chest pain, what are our main system?
Cardiovascular,
Cardiovascular. Anything else?
respiratory.
Respiratory. Brilliant. So these two will be our main system. And then other system, we will just quickly cover. Other system, we don't need to be detailed. So for cardiovascular system, we will go in detail. We will do inspection, palpation, auscultation, everything. Same for respiratory. If time permits, we will do the detailed respiratory exam. Otherwise, just in a single line, we will finish it. You will see how we do it. And then we finish with, just quickly say that I would like to finish with all other systemic exam, which you don't need to ask anything specifically. And we always finish with office test. What is office test? It's a test that you can do bedside. It's not a chest x-ray. I know you can say that bedside chest x-ray is there, but in exam, it's not usually the office test. So there are a couple of few office tests that we can ask in the exam. One is urine dipstick. Only relevant if a patient has UTI, then yes, we will be asking that. If we want to look for proteinuria, hematuria, then we will ask for it. Then ECG, that's the most relevant office test in a chest pain patient. Urine pregnancy test, if it is an obstetric case, then yes, this is important. We can also sometimes ask ABG or VVG. If a patient has lung condition, we can ask for any known spirometry result. Okay, but mostly we will be asking this. And another one is blood sugar level. Sorry. So again, if it is relevant. So blood sugar, urine dipstick, ECG, urine pregnancy test. These are the common office tests that we can ask in the exam. Okay, now if you look over here, the format that we are showing you, it's going to be always. So general appearance, vitals, BMI. I always keep BMI with the vitals because I don't want to forget it. Especially if it is relevant, I will ask it. If not relevant, I will not ask it. Pickled, only the relevant pickled, main system, followed by other relevant ones, and then office test, finish the physical exam. All right, so that's the format that we are going to use in every case. Now, it might be a little bit tricky still now, I understand, but when we are going to do a case, you will understand what I meant by this. So let's move on. Once we finish the physical examination from examiner, then we go on. Usually the next task will be explain the diagnosis or differential diagnosis to the patient. Sometimes the task will be explain diagnosis differential and management. So if management is also there, then this is how we are going to start. So when we explain a condition, we explain the diagnosis first. And then we explain what is that diagnosis means. Like you can say that most likely you have got a condition called acute pericarditis. So then you explain what is acute pericarditis and you explain the cause of it. What are the common clinical feature of this condition? Is it common or uncommon? And if sometimes you can also add some complications related to that condition. So when we start explaining a condition, we explain the diagnosis first, then we explain what it means and what's its cause, what's its clinical feature, is it common, uncommon, and complications related to that. If differential is a task, then we definitely say some differential diagnosis. And then we need to know where is the patient. If this patient is this patient in the emergency department or it's in the GP clinic? When you read a question, it's always important to know what's the setting because treatment can be different based on the setting. If it is an acute chest pain and you're thinking that this patient has got acute MI, you can't treat that patient in a GP setting. That patient needs to go to emergency. Okay, so we need to know that whether we can treat this patient in the GP setting or we need to send the patient to the hospital. We need to talk about what are the investigations related to that disease and how we are going to manage this. So that's our structure for the diagnosis and management. Okay, so this is what we are going to do in every case that we will do in medicine. So we explain the diagnosis, the cause, clinical feature, common complications, differential diagnosis. Are we going to treat the patient in the GP setting or are we sending the patient to the hospital? What are the relevant investigations and how we are going to manage this patient? That's what it involves. Now that you know the structure, we can move on to our first cluster. The cluster that we are going to focus tonight is chest pain cluster. Super important. Many of you will get one case from here in your exam. When we do a case, especially when we do a cluster, the cluster-based approach is mainly focused on knowing the differential diagnosis and using the differential diagnosis to solve the cases related to this. So first of all, any cluster, we need to know the differential diagnosis of that cluster. So what are the differentials for chest pain? Most important, cardiovascular. So it could be angina, could be myocardial infarction, could be acute pericarditis, aortic dissection, aortic stenosis. These are usually the common causes of cardiac chest pain. Then we have respiratory causes. It could be pneumonia, pulmonary embolism, pneumothorax. Now, you can add lung cancer here. Sometimes lung cancer can come as a chest pain, but not very common. GIT related. So we should know if it is gastroesophageal reflux disease, peptic ulcer disease, could be esophageal rupture, could be esophageal spasm. Okay, so in case of GIT, mainly reflux or peptic ulcer disease, that's common. And esophageal spasm can be there, esophageal rupture can be there. Not very common, but yes, we need to ask them. Musculoskeletal is one of the most common cause of chest pain, so do not forget that. Rib fracture related to trauma, muscle strain. Patient went to a gym and like after 5 years, for the first time, patient went to a gym, started doing a lot of heavy lifting and ended up getting a chest pain. All right, so most of the time that patient must have just strained the chest muscle. So that is very common. We should not forget that. And costochondritis, where this is it's the number one cause of a tender chest pain. None of these causes will cause a tenderness on the chest wall, except costochondritis and rib fracture. These two will be tender to touch. Okay. Neurological, sometimes prolapsed disc, especially prolapsed thoracic disc, can cause a radiating pain to the anterior part of the chest. So that's one thing. And herpes zoster or shingles can also present as chest pain. And then we should not forget about psychological cause such as panic attack or any anxiety related. So these are our main differential diagnosis for chest pain. And I want you to remember most of them because this is important cluster. And sometimes you might need to ask a lot of differential in this kind of cases. So first, CVS, respiratory, GIT, musculoskeletal, neurological, and psychological. Okay. Now, each of these diseases has their specific symptom, such as if we give you a slight idea, we will go into the history just in a bit. Angina patient will complain a chest pain on the left side of the chest, and they will complain that it feels like constricting, it feels like grabbing, pressure feeling on the left side, and it can radiate to the both arms. It can radiate to the neck and jaw. With that, patient can have associated nausea, vomiting, sweating. But the difference between angina and MI is that angina will get better within 5 to 10 minutes after taking a rest, whereas MI chest pain will persist for more than 20 to 30 minutes. Okay? But the symptoms are pretty much same. And or angina pain is almost always related to something exertional. So patient doing gardening suddenly started having the pain. Patient was walking or walking uphill, suddenly started getting a left-sided chest pain. That's when we think of cardiac cause. Okay, so angina and MI pretty much the same symptom, but it's the duration of it, and MI pain does not get better with rest. Pericarditis, it's also sharp stabbing pain, can be retroesternal, can be left-sided, but it's a kind of a positional pain, which means that pericarditis pain will be sharp and stabbing, but it will get better when they lean forward, but worse when they lie down. This kind of pain also looks like a pleuritic pain, means that it will get worse with deep breath or inspiration. And pericarditis patients usually have a recent viral illness. Aortic dissection, it's a sudden, severe, excruciating, tearing pain, usually central pain, which goes to the back. Aortic stenosis usually comes as episodes of chest tightness or pain, shortness of breath on exertion, and dizziness or syncope. That means loss of consciousness. Then we have got respiratory causes. As part of respiratory cause, pneumonia is important. So pneumonia patient will have chest pain, but they will have fever, shortness of breath, and most importantly, cough. So chest pain, fever, shortness of breath, and cough, that's pneumonia. Pulmonary embolism will come to us with pleuritic chest pain, which means that this patient will have chest pain that get worse with deep inspiration. And they always have some kind of risk factor, maybe a long distance travel. Pneumothorax, main presentation is pleuritic chest pain plus shortness of breath. Reflux peptic ulcer disease, they are related to food. And the pain is kind of burning chest pain. That's why we call it heartburn. Esophageal spasm will have dysphagia, so swallowing difficulty, plus an intermittent chest pain. So all of them has some particular symptoms related to it, and that's what we are going to focus. And in your mind, you need to know this because that's what will be your questions related to this differential diagnosis. Okay, now we can move on because we will discuss all of them anyway. So I already said the chest pain that is suggestive of acute coronary syndrome, it's crushing, heavy central chest pain, and that can radiate to the arm, neck, back, and jaw. Left arm pain is common, but bilateral or right arm pain is more specific. So if a patient has got right arm pain, do not just rule out the possibility of a MI. Acute coronary syndrome also will have associated shortness of breath, nausea, sweating. Let's start the history. How we take history in a chest pain patient. So this is what we are going to follow. So we've got a patient, let's say 50-year-old coming with a chest pain. How we're going to start that case. So let's say patient name is Jack. So you'll say, hi Jack, this is Dr. Arshan. I'm one of the doctor in this emergency department. Very nice to meet you. John, how are you feeling now? Jack, I understand. So what will happen that when you say, Jack, how are you feeling now? Jack will say, Doc, I've been feeling this chest pain and it's not going away. So patient is scared. What will you say next? You'll say, Jack, I understand chest pain can be very scary, but I'm here with you and I'll do everything possible to manage your condition. But before I ask you any questions, I need to make sure that you are stable enough to talk to me. So please excuse me for a moment. I'll come back after talking to my examiner. So you are not talking to the patient until now. So you excused from the patient. Then you turn around. So if you are sitting on a chair, you turn around and you look at the examiner, and you don't need to stand up for the examiner. You can sit. That's fine. Just say, dear examiner, I would like to know if my patient vitally stable for further history. Okay, that's the question we are going to ask to the examiner. Dear examiner, is my patient vitally stable for further history? Two things can happen. Examiner can give you the vitals, or examiner can just say, stick to your task or move on. Something to say that he doesn't want to give you the vitals at this point. If he does give you the vitals, then listen carefully to make sure that whether this patient is vitally stable or not. So examiners sometimes, if they want to give you the vitals, they can ask that, what do you want to know? Then you will say that I would like to know the blood pressure and pulse rate and rhythm. Examiner will give that to you. And then you can ask, I would also like to know the respiratory rate, temperature, and saturation, please. Now, if any time during your exam, you find that when you ask the vitals, an examiner gave you a vital which looks like patient is unstable, what to do next? Any unstable patient, there is a different approach that we follow. I have written it somewhere, but let me discuss that from here. So if a patient is unstable, let's say the patient's blood pressure is 90/60. or patient oxygen saturation is 92. So what will you do then? In that kind of case, for every case, we will say that, dear examiner, I would like to transfer my patient to the resuscitation cubicle. I'll call for help, hook the patient to a ECG monitor, and I'll also insert two large bore IV cannula. I'll take blood for necessary investigation. I'll start the patient with IV fluid and start my patient with oxygen. Now, it's based on these vitals. It's not based on the chest pain. Chest pain is a different thing. We'll talk about it. So, if a patient is hemodynamically unstable, before you proceed to the history, you will at least start managing that patient. At least transfer the patient to the resuscitation cubicle so that someone can keep an eye on him. So you take the patient to the resuscitation cubicle, call for help, attach the patient to the continuous ECG monitor, insert IV line, take blood for necessary investigation. For a chest pain patient, what is the necessary investigation? Troponin. And then if the patient is his blood pressure is low like that, you can start IV fluid, but again, very cautiously, making sure that this is not a cardiogenic shock. Also, if oxygen is low, then start the patient with oxygen. Okay. So far, we don't know the cause of the pain yet. So it's not needed that we start any other treatment just yet because we don't know the cause. Okay. All we know is that this patient's blood pressure is low, this patient oxygen saturation is low. If I can't be sure that this patient is not having heart failure, then I will not even start the fluid yet because I can just hold it for now and make sure I know it is not a heart failure patient and I'm giving too much fluid and making it worse. Okay, so I'm just giving a general idea that it's not related to chest pain case, but as a general scenario, if initially you find out that patient is vitally unstable, this is what you need to do. You take the patient to the resuscitation cubicle, call for help, attach to the ECG monitor, insert IV line, take the blood for necessary investigation, and then if blood pressure is low, start IV fluid. If oxygen low, start oxygen. Okay, makes sense, everyone? We don't do this code blue in Australia, so it is resuscitation cubicle. That's what we would normally do in the hospital setting. Okay, once we have done this part, let's say when you ask this that, dear examiner, I would like to know if my patient vitally stable for further history. Examiner said yes. You thank the examiner, come back to the patient and say, thank you for waiting. Now, Jack, could you please tell me how bad is your pain on a scale of 1 to 10? Let's say patient say that my pain is 7 by 10. Now, so I'm so sorry to hear that. Do you have any allergies to any medication? No, doctor. Well, I'm going to arrange a painkiller for you and hopefully you will feel comfortable. Now, in here, if it is a chest pain case and you don't know the cause yet, the thing is that this is a general scenario. We don't know the cause. What painkiller we will start? Paracetamol. If we know that this patient has got an acute myocardial infarction, that is the time we will start the patient with morphine or fentanyl or a GTN spray. Okay? Depends. At the moment, we don't know anything about the cause of the pain. So we're just doing a general management. This patient has got a pain. I'm just going to give the first common painkiller that is available, which is paracetamol. Okay. So please tell me how severe is your pain in a scale of 1 to 10. Patient said 7 by 10. Any pain above 5, we will offer a painkiller. Okay, so do you have any allergies to any medication? No. Well, I'm going to give you a painkiller to make you comfortable. Now, do we need to say that I'm going to ask a nurse to give you the medication, or do you need to pretend that you are talking to a nurse in the exam? No, you just say this line. It's all about pretending that, yes, we are going to do this. We don't need to give the medication to the patient because this is just a simulated station. Once we have done this initial part, remember these initial parts are really important. Making sure patient is stable, making sure you offer a painkiller when it is needed. Once you have done that, you go to your main question. So the main question is here, the chest pain. So all of you know how to ask a chest pain question. So the chest pain question will start with Socrates or short Sarah. Same thing. The short Sarah or Socrates involves asking the site of the pain. So where exactly is the pain? When did it start? What is the characteristic of the pain? Does it radiate? Any associated symptom? How long you have the pain? So the time or duration, exacerbating or relieving factors. So anything makes it better or worse, and how severe it is. So that's what we are going to ask here now. So before you ask these questions, you always start like this. So Jack, could you please tell me a little bit more about your chest pain? So you always start with an open-ended question because most of the time with this question you will get a lot of information from the patient. So patient will say, Doc, I was just walking on the hill and suddenly I just felt a grabbing chest pain on my left side. Okay, so you already found a lot of things. So if something is given by the role player, you don't ask it again, right? So, but basically that's what we need to find out. Let's say we already know from the stem, the question mentioned that the chest pain started 30 minutes ago. Do I need to ask again when did it start? No. That's how you will waste time by asking the already known thing twice. And also examiner doesn't like it because it shows that you did not read the question properly, or if the role player already said that just an hour ago I started having the chest pain, and your next question is when did it start? That just mean that you are not even listening to the patient. So those are very bad thing to do in exam. So if something is given on the stem, if something has been said by the role player already with your open-ended question, please do not ask those questions again. But as a whole, we need to know when did it start, what exactly you were doing at that time. Did it come suddenly? Is it for the first time? If it happened previously, ask about the previous episodes. What were you doing at that time? How long did it last? Okay, what did you do to make it stop? So we ask a little bit more about the previous episode in that case. Is it continuous or on and off? Can you exactly point out the site of the pain for me? Or where exactly is the pain? Does the pain go to anywhere? So we don't use radiation because that's a medical jargon. When we talk to the patient, we ask question as simple as we can. So does the pain travel anywhere? Does the pain go to anywhere? Can you describe how the pain feels like? So characteristic of the pain is really important to know about the cause of the pain. If it is a sharp stabbing pain, it can be pericarditis. If it is tightness, pressure, heaviness on the left side of the chest, likely to be acute coronary syndrome. If it is sudden, severe, excruciating, tearing kind of pain, then likely to be aortic dissection. So type of the pain or characteristic of the pain is really important to ask. Anything makes it better, anything makes it worse, especially like deep breathing, coughing, or exertion. So you can ask this here, or you can ask during the differential diagnosis as well. So what you asked is if it is a pleuritic chest pain or is it more towards cardiac. So if it get worse with deep breath or coughing, then suggest a pleuritic chest pain, which normally we find in patient with respiratory conditions. So pneumonia, pneumothorax, and pulmonary embolism. These three is usually what it gives pleuritic chest pain and also pericarditis. These are the main four causes of pleuritic chest pain. After that, so you finished your pain questions. Then you ask the associated question. So along with the chest pain, any associated shortness of breath, racing of the heart, which is the palpitation. We don't ask palpitation, we ask racing of the heart, nausea, vomiting, or any excessive sweating. What you did is that you also asked all the MI related questions or all the cardiovascular related questions. So with your associated question, you started asking about the differential diagnosis because that covers almost all the cardiac causes. So along with the chest pain, any associated shortness of breath, racing of the heart, any nausea, vomiting, any excessive sweating. Okay? So if we go back, you can see that angina, MI, pericarditis, dissection all gets covered with the same questions. So we asked about the cardiovascular differential diagnosis by asking this associated question. After that, we move on to some other differential. So we can still ask few questions related to pericarditis, especially does the pain get worse when you lie down? Does it get better when you lean forward? Any recent viral illness? Because most of the time pericarditis is followed by a recent viral flu-like symptom. And as you know that pericarditis pain will be worse with lying down and better with leaning forward. So that we can ask. For aortic stenosis, we know that we already asked about chest pain. We already asked about shortness of breath. Only thing that is left to ask is dizziness or loss of consciousness. So any dizziness or sudden blackout. For aortic dissection, nothing needs to be asked because that is already covered by your chest pain question. Okay, so serious questions are all covered. Next, we move on to the respiratory causes. So for pneumonia, any fever or cough, because we already asked chest pain and shortness of breath. Anytime you get something positive, let's say this is a case of pneumonia, definitely fever and cough will be there. You need to ask detail about those. So if you get something positive, you ask a little bit more about that symptom. For pneumothorax, any trauma to your chest, any known lung condition such as asthma or COPD. So pneumothorax, most of the time it is primarily a spontaneous pneumothorax where there is no known cause. Sometimes if a patient has got known lung condition like asthma, COPD, then that can also be a predisposing factor for pneumothorax. But pneumothorax patient also present with chest pain and shortness of breath, which you already asked. So nothing you can add here anymore. For pulmonary embolism, same, they come to us with pleuritic chest pain and shortness of breath. They can also have tachycardia or palpitation, so that's also you asked. So all we need to ask is that if there is any kind of risk factor to have a PE in this patient. So any recent long distance travel, any previous or family history of clot formation in your legs or lungs. So as you can see by this time that we only asked maximum 2 to 3 questions for each disease. We don't need to ask everything. So we finished the respiratory causes. Then we have GIT causes for gastroesophageal reflux, any relationship of this pain with food, any heartburn. You can also add in here any burping, any belching, any acidic taste or bitter taste in your mouth. Does it get worse with lying down or bending forward? So reflux will get worse with lying down or bending forward. So if we have time, we can ask more questions, but we will not have that much time. So just ask any relationship of this pain with food, any associated heartburn, burping, belching, or bitter taste in your mouth. For peptic ulcer disease is the same question. We don't need to ask more because peptic ulcer disease will have pain in the epigastric region, which will be related to food. For esophageal rupture, you can say that did the pain come after vomiting? So esophageal rupture usually had a history of vomiting vigorously and then ended up getting a ruptured esophagus. And they also have hematemesis, which is vomiting of blood. So you can just ask that any vomiting of blood or did it start after vomiting? For costochondritis, is the chest sore to touch? As I said that this is a condition where the costochondral junction meets, that junction will be sore and tender and inflamed. So if you say that is your chest sore to touch, if it is positive, then you can think of costochondritis. For musculoskeletal chest pain, so any heavy lifting or any excessive strenuous activity that you have done recently. So that will cover your musculoskeletal conditions. Neurological, we have shingles or herpes zoster. Herpes zoster start with a kind of a burning pain, followed by a few days later, there will be a vesicular rash on that spot. The rash will be kind of a blister, like a chicken pox kind of rash, and the blister will rupture, form a ulceration there. So initially it starts to have a chest pain, like a pain on that spot, and then they will have a vesicular rash. So you just ask the patient that any rash on your chest. And lastly, we have anxiety attack or panic attack. So are you generally an anxious person? Do you worry a lot about most of the trivial things? Any stress at your home or work? So quickly ask about any psychological things going on. And lastly, we'll finish with SADMA, past medical and family history. So do you smoke, drink alcohol? You can ask recreational drugs, not very important. Do you smoke or drink alcohol? Any regular medication that you take? Any known allergies? Any past history of heart condition such as high blood pressure, high cholesterol, any other heart disease, any history of diabetes, any family history of heart condition. So that way you will finish your history. Okay, so to recapitulate, your history will be starting with introduction, make sure patient is vitally stable, make sure you offer painkiller, and then you start asking the pain question in detail. You go to the differential, which you start with the cardiovascular question, and then you ask the respiratory causes, GIT causes, musculoskeletal causes, neurological and psychological causes, and then you finish with SADMA, past medical and family history. You thank the patient, and then you go to the physical examination from examiner. Is this clear for everyone so far?
Yes, doctor, thank you.
Brilliant. Now, when we go to the physical examination from examiner, excuse me, so what we are going to say? So you'll say that, Jack, thank you for all the information. Now I'm going to talk to my examiner and I'll come back to you. So please excuse me for a moment. You turn towards the examiner and say, Dear examiner, I would like to do physical examination on my patient. First of all, on general appearance, is he comfortable or in distress? Examiner will give you some finding. I would like to know the vitals, so same blood pressure and pulse. I would also like to know the respiratory rate, temperature, and saturation, please. Is there any pallor, cyanosis, or edema? In cardiovascular exam, so we start with the neck. First, then you will say, then I would like to start checking at the neck for any raised JVP, any carotid bruit that I can hear. So examiner will say no. I would like to focus on cardiovascular system now. On inspection, any visible cardiac impulse? Examiner says no. On palpation, is the apex bit normal in position? Any palpable thrill? Any para-sternal heave? That's what we do in palpation. So apex bit, palpable thrill, and para-sternal heave. Palpable P2, not that important anymore, so you can forget that. On auscultation, apart from S1 and S2, is there any other added sound, such as any murmur or pericardial rub? Murmur, in aortic stenosis, you will get murmur. If it is pericarditis, you can get pericardial rub. So that's because this is our main system. We are doing it in detail: inspection, palpation, auscultation. If you have time, you can do respiratory system in detail, but you will not have that much time. So you'll just say, then I would like to do respiratory exam. I would like to know if there is bilateral equal air entry, any added sound like any wheeze or crepitation. So ask about, is there bilateral equal air entry? If you don't like to ask that, you can always ask that, is the breath sound normal on both sides? Any wheeze or crepitation? And that's the main system you need to ask. Even if you don't say any other system, it's fine. But do not start abdominal exam, neurological exam at first in a cardiac case, because that's the time examiner will not like this. So always start with the most relevant system and then forget about anything irrelevant. Dear examiner, is there any office test available, such as any urine dipstick, blood sugar, or ECG? Now remember one thing, blood sugar is important for chest pain patient because diabetes is a risk factor. ECG is very important. Urine dipstick, not that important. So even if you don't ask it, it's okay. So that's going to be our physical examination from examiner. Okay, clear everyone? So do you know how to ask it now? How you're going to ask the physical examination from examiner? Okay, yes, I can repeat this again. Yes, so in a room, there will be two people. One will be your examiner who will listen and look at what you're doing. And then there will be a role player, which will be the patient. So two different people is there. Examiner will be just standing behind you. They usually don't ask a lot of questions. They just listen to what you're doing and then they will do the marking. And the patient will be talking to you and give all the informations. Okay. Now always remember to look at the task. This task is ask physical examination finding from examiner. That means for this task, you will have to talk to the examiner. The history will be take history from the patient. So for the history, you will talk to the patient or role player. Okay. So for physical examination finding from examiner, we will say, dear examiner, I would like to do physical examination on my patient. First, on general appearance, is my patient comfortable or in distress? Examiner gives you the finding. I would like to know the vitals of my patient. So you ask the vitals. Is there any pallor, cyanosis, or edema? I'd like to check the neck. Is there any raised JVP or carotid bruit? I would like to focus on cardiovascular system now. On inspection, any visible cardiac impulse? On palpation, is the apex bit normal in position? Any palpable thrill, any parasternal hip? On auscultation, apart from first and second heart sound, is there any other added heart sound or any murmur? Any pericardial rub? I would like to also do the respiratory system. Is there bilateral equal air entry? Any added sound like crepitation or wheeze? Is there any office test available, such as blood sugar or ECG? That's what you are going to ask to the examiner. Examiner will only give you findings as you are asking it. Let's say you did not ask about JVP or carotid bruit, examiner will not give that finding to you. Does it make sense now?
Sir, excuse me.
Yes. Yeah.
Sir, when I am taking history from the patient, should I ask the examiner about his general appearance? I'm already taking history from the patient.
Now, physical examination has a different finding. So you are not wrong in that way, Rajiv. Very good question. That general appearance, sometimes if we just say that, dear examiner, I would like to know the general appearance of my patient. Sometimes examiner can give you some findings that might be relevant to the case, not for chest pain, but some other cases. Like let's say we are in a patient who has snoring. So a patient who snores at night, when we ask them the general appearance, the examiner says, yes, there are some adenoid faces in this patient. So general appearance not always just is my patient comfortable or in distress. Sometimes there might be more to that. If you just use the term general appearance, if there is something the examiner is supposed to give to us, they will give to you just by asking that. Okay.
Okay, sir.
Yeah, but you are right that it's not always important. So if we are not looking for a lot of things in general appearance, it's okay not to even ask it. So if you don't ask the general, now I always keep it as a format. The reason is that format makes it easy for everyone to remember. So it's better that we always ask, like in every physical examination we start with general appearance, because a patient's mental status, a patient's look, the posture, everything gives us information that might be relevant to the case. But when we are asking history, we know those things. But again, if there is something more extra as a finding that we should know on general appearance, sometimes examiner give it to us. So it's better to ask it instead of not asking it. Okay. And that's very common to start with general appearance in a physical examination.
Sir, I have a query. That
Yeah.
is, during history taking, we are already asked about the vitals of the patient. Again, during physical examination, should we ask again the regarding vitals?
Only if you have got it, if you haven't got it at first. So you asked it during that initial questions, examiner said, uh, proceed or stick to your task, or it's stable. What if you don't know the vitals at first? Then yes, during your physical exam you will ask it explicitly like this. But if you initially already found out vitals from examiner, then you don't need to ask it again.
Okay, sir. Thank you.
Thank you. All right, next. Now we are moving into the task or into the cages. So this is your format for all the chest pain cages that can ever come in exam. So you don't need to remember history or physical examination case by case. You just have the format and you utilize that for any chest pain cases. Okay, like this one, we have got a 50-year-old tram driver. So we've got a 50-year-old tram driver presents with sudden onset chest pain for 2 hours. Take focused history from the patient, PE from examiner, and give the diagnosis and differential to the patient. So that's your task. So 50-year-old man. Now, usually in exam, they will also say, is it a GP setting? Is it an emergency department? They usually mention that. So our first task is history. So when you will use the format of chest pain, these are the positive points you will find out in the history. So you need to ask those questions and find out findings from the patient. These positive points will not be just given like this. You find it out by asking question. So for a pericarditis patient might say, started having the chest pain for the last 2 hours. It's getting worse with lying down and deep breathing. Better by leaning forward. Sharp stabbing type of pain. Remember, sometimes pericarditis pain can go to the back and in between the shoulder blades. And they can also say that they had a flu-like illness a week before. No other symptoms that you have found. So if you have found a patient who has a sharp stabbing chest pain, central left-sided, and it's getting worse with lying down, better with leaning forward, and also worse with deep breathing, had a history of flu-like symptoms, definitely we can think of pericarditis as our diagnosis. So the next task will be physical examination from examiner, which you will be doing exactly the same that we have shown you. In pericarditis, you will not get any positive findings from the examiner. So because physical examination is usually normal in this patient, except in some patient, you can get a pericardial rub. Not always. Examiner doesn't say pericardial rub. They say that, yes, like if you say, is there any other added sound apart from S1, S2? Examiner sometimes say, yes, you can hear a pericardial noise. So they say pericardial noise. They don't say the rub, because pericardial rub, if they give it to you, you should know immediately that it's pericarditis. So they say noise. Okay. So it's the same thing. Now, ECG is important for cardiac cages. Now, we don't take ECG class in the course, but what we do, because you should learn ECG in your MCQ classes anyway. And if you are our first aid MCQ course student, you already have the ECG class that we take for all of you. Now, if you haven't, then what we do for course student, that there is a ECG class recording that we provide in the student portal. It's definitely a good idea that you go into that class and learn about the basics of the ECG. Because when you're a AMC clinical candidate, we think that you know the basics of ECG. You should know. Okay. Now, but still, I will go through the main ECGs that's important for exam anyway with you for the cardiac clusters. So if we have got a patient with chest pain and an ECG is given in the exam for interpretation, what will you do? We know that V1 to V6, these are our chest leads or anterior leads, and lead 1, lead 2, lead 3, AVR, AVL, AVF, these are our limb leads, right? If a patient has chest pain, we should always look at the chest leads first, because that will give us more information. So we look at the chest leads, and what we look for? We look for any ST elevation, any ST depression, any T wave inversion. So have a look on here. So first of all, the normal ECG should be like this. So this is the P wave followed by Q, R, S, and that's T wave. And then again P wave, Q, R, S, T wave. That's the normal, right? So you can find out that this is the line that we see. These are all straight. They're all in the same plane. This line is what we call as isoelectric line. Now, in a patient who has ST elevation or depression, you can see that the ST will go up. That's ST elevation. If ST goes below this isoelectric line, that's ST depression. Okay? That's as simple as it is. If you understand this, it's very easy. Now have a look on this side. So V1, we see that everything is on the isoelectric line. That's fine. V2, let's have a look. So this is the P wave. And then There is a bit of a bundle branch block, but don't worry. And then still can't see a lot in here. There is a subtle change. If you see here, this is the isoelectric line. The ST is over here. It has started to become elevated, right? That should be where the ST is. Still not that evident, but there is definitely some ST elevation in here. And there are different kind of ST elevation. This ST elevation is what we call concavity upward. So it's concave upward. And that is a classic ST elevation for pericarditis patient. In V3, you can see it more. So this is the isoelectric line, but see that this is where the ST elevation is. So definitely it has elevated. V4, we can see the ST elevation. V5, ST elevation. V6, ST elevation. So almost all of this chest lead has got ST elevation, and the ST elevation has got this concavity upward. Then we look at the limb leads. When we get anterior lead having ST elevation, we look at the lateral leads. What are the lateral leads? Lead 1 and lead AVL, or we call it high lateral leads. Look at the lead 1. Lead 1 also has ST elevation, and lead AVL also has a subtle ST elevation. Okay, so we've got all of this anterior lead, lateral lead having ST elevation. If this was an acute myocardial infarction, that should be it. There should not be any other elevation in this lead 2, 3, and AVF. Lead 2, 3, AVF are the inferior leads. So if it was the anterior MI or anterolateral MI, ideally, we should not get ST elevation in these leads. We should get ST depression, because if it is anterior MI, we should get reciprocal ST depression in the inferior leads. But that's not what you will get in a pericarditis patient. In pericarditis patient, almost every lead will have ST elevation, such as in this lead 2, you see that there is ST elevation. Lead 3, you can't see much. That's normal. Lead AVF, we can't see much because of the bundle branch block type of pattern, but there is a bit of ST elevation we can assess here. But even if we are not sure from 3 and AVF, lead 2, still we can see there is ST elevation. That is more than enough to say it is not a MI. All right. So when we get almost all the leads throughout the heart having global ST elevation, and the ST elevation has this kind of concavity upward pattern, like we say, chair-shaped pattern, that's pericarditis. Does it make sense to everyone how to read the leads and how to know what is ST elevation and all? All right. So if any of you don't understand, please make sure to ask. It's totally fine. If you're not understanding, you can always ask. Okay. Yeah. So if there is widespread ST elevation, that is acute pericarditis. So how we are going to explain this to the patient? So to the patient, we are going to say, always remember, in this exam, you are a junior doctor. You are not a specialist. You are not a consultant in clinical exam. So the highest rank you will have is junior medical officer or resident medical officer, or you can be just an intern. So that's what you will be. So you can't manage a patient fully. Most of the things will be managed by your registrar or the consultant. So you will always say that most likely. You don't say you have this condition. I'm sure that you have this. We always say, Jack, thank you so much for your waiting. So from the history, physical examination, and also the ECG, most likely you are having a condition called acute pericarditis. Do you have any idea what it is? No, doctor. Well, let me draw a picture for you. So, in your exam, you will have a pen and paper. So, always try to draw a little bit. Say that this is our heart, Jack, and heart has got an outer covering which we call pericardium. You have got inflammation of this outer layer of the heart. Most likely, it is due to the recent viral infection that you had. Apart from this virus, it can be due to other causes, such as it could be some metabolic condition like kidney conditions, sometimes could be connective tissue diseases like lupus, could be related to trauma, could be sometimes even cancer, sometimes even without any known reason. Please don't get scared about other causes because you had a viral infection and that's most likely causing this inflammation. Because if you say all of this lupus, cancer, kidney failure, patient will be scared like hell. So when you say something like this, always say, like we call it sandwich approach. We give something really scary to the patient and then immediately say that please don't get scared because most likely it is not any of this. You had a recent viral infection, so that's most likely causing it. Now, again, only if it is true. We are not just going to say this if patient actually have a kidney failure or uremia and that's causing it, we will not say that line. We are not going to use the sandwich approach in that case, right? So this patient had a viral illness, so that's most likely causing it because that's the most common cause. So you can always assure the patient. Then you say, as the covering of the heart is inflamed, it's causing this sharp stabbing chest pain, which get worse when you lie down and gets better when you lean forward. So what we have done, we explained the diagnosis. We said, what does it mean? We said, what's the cause? We said, what's the clinical feature? Okay. Sometimes common, uncommon complications, we don't need to always mention it. It depends. But definitely we need to say the diagnosis. We need to say what it is, what's causing it, what's the likely clinical feature. Now, if this was a case of differential diagnosis, you will also need to mention all the differential diagnoses one by one. So there will be case where your last task is give diagnosis and differential to the patient. So at that time, you will say, apart from acute pericarditis, it could be due to other reasons as well. Then you will have to give all differential diagnoses one by one and give reason why it is not. So you can say it could be due to acute myocardial infarction or heart attack, but your chest pain does not go with the heart attack kind of chest pain because in that case, your chest pain will be left sided. It will be constricting, heaviness, or pressure feeling. And also, the ECG does not go with it. It could be due to a condition called some valve disease in your heart, but you don't have any murmur or you don't have any associated dizziness, blackout with this condition. It could be some lung condition like pneumonia, but you don't have fever, cough. It could be a condition which you call pulmonary embolism, where you get clot in your lungs, but your chest pain does not go with it and you don't have any risk factor associated with it. Could be due to pneumothorax, where there is air in the external part of the chest or lung, but in your case, your chest pain does not go with it. It could be musculoskeletal, where your chest might be sore to touch, but in your case, it's not. Could be sometimes gastrointestinal causes, such as heartburn, which is related to reflux, but you don't have any burping, belching. Your pain does not get worse with eating food, so it is unlikely in your case. So what we do that we give all the necessary relevant differentials that we asked in this patient, and we say why it is not the diagnosis in your case. That is a really a good idea in exam. If you have time, even if differential diagnosis is not in the task, it's a good idea always to mention them. Okay. Now let's say your task is not only just diagnosis differential, you also need to talk about the management. In that case, what will you do? So you'll say, let's say this is the hospital setting. So you'll say, let me assure you, Jack, it is not a heart attack, but still I need to confirm my diagnosis and exclude heart attack. So I would like to keep you under observation in the hospital. I will also talk to my senior, and a heart specialist will come and see you. So we always involve our senior and relevant specialist in the management. In the meantime, I will arrange some investigation like full blood count, inflammatory marker, kidney function, a repeat ECG, and a cardiac enzyme called cardiac troponin to rule out any possibility of a heart attack. The specialist might want to arrange an echocardiogram, which is basically a scan of your heart to rule out any fluid collection around the heart called pericardial effusion, or even to rule out inflammation of the middle layer of the heart called myocarditis. So we do an echo. Once it is confirmed, a specialist most likely will start you on a combination of medication called colchicine for 3 months with an anti-inflammatory medication such as ibuprofen for 1 to 2 weeks. So this is from therapeutic guideline. The management of acute pericarditis is colchicine for 3 months and plus one of the following, either aspirin for 1 to 2 weeks or ibuprofen. Most likely you will be able to go back home after the test results are back, but please avoid any excessive exercise for the next few weeks for proper healing and to prevent worsening of this inflammation. I want you to know, Jack, that this is not uncommon, and with proper treatment, this can be easily managed. So always finish with something reassuring at the end. Do you have any questions? All right. So that's pericarditis management, guys. Do you have any questions so far?
Dr. Arshan,
Yeah.
I would like to ask you about the focused history. When we get the symptoms suggestive of the pericarditis, still we have to ask the question for other differential like respiratory and peptic ulcer.
Yeah. If you're depend on the task, if the task is history, physical examination, diagnosis, and differential, you have to ask it. Without asking those questions, how you're going to talk about the differentials, right?
Okay.
So very important. And every case, it's not about only finding, let's say in your first differential, you found out everything about that case. Are we not still exploring it? We should, because a patient can have multiple things together. So we should always ask for most of the relevant differential in this kind of case.
Yeah, thank you.
But there is a difference here, Sergeant. I will do another case you will see today.
Mm-hmm.
Sometimes they give you a patient with chest pain and they
Mm-hmm.
give you the ECG, and you can see the ECG on the stem. Like
Okay.
ECG showing that this patient has got pericarditis or ECG showing acute MI. In
Mm-hmm.
that patient, they ask for relevant history. That
Oh, okay.
patient, you definitely will not need to ask about respiratory, musculoskeletal, GIT. That patient, you don't need to. That patient focused history only related to cardiac. Okay?
Okay, thank you. Yeah.
Thank you. All right. Talking about it, so moving on to the most important question for anything related to cardiac is acute myocardial infarction. Very important. A lot of questions come from here and lot to know. A 55-year-old man comes to your emergency department with a sudden onset crushing chest pain. You are in a tertiary hospital. So in a chest pain patient, we should always know that is it a tertiary hospital where everything is there, or is it a rural hospital where PCI might not be available? So we always know that. And there are different cases that comes in exam. Some cases are, you know, the patient is in a tertiary hospital. Some cases you are in a rural hospital. So take history from the patient, ask for investigation from the examiner, and explain to the examiner. So that's a different task. We haven't done it yet. So this is a task where you need to ask investigations, that what investigation you want to do for that patient, And if you ask the relevant one, examiner will give you the findings, or examiner will give you the investigation result. And then you need to explain that investigation to the examiner. Like in a chest pain case, what is the most important investigation, guys?
ECG.
ECG, right? So you ask the ECG, examiner will show you the ECG, and then you need to explain that ECG to the examiner. How to do that, we will show you today. And your last task is explain the likely cause of his chest pain and immediate management to the patient. So always know the task. Task is not going to be same every time. So knowing the task and just stick to that is important. Let's say in this case, there is no PAFE, but you haven't read the task properly and you started asking PAFE, you will fail that case. Okay, because most importantly, you did not read the case, and also you will run out of time. All right, so please make sure that you know the task by heart. So that was one type of question where you did not see the ECG on the stem. The second task or second case was like this. 55-year-old comes to the ED, sudden onset chest pain. You are in a tertiary hospital, but now they have given the ECG to you. So on the stem, you will be able to see the ECG. Your task is to take a brief history from the patient. So this becomes a focused history. Explain the ECG to the examiner. Explain the likely cause of his chest pain and immediate management to the patient. So see that how the task becomes different case by case. That's really important to notice. So in this case, you already know this is a patient who has crushing chest pain and this is the ECG. So if we read the ECG here, what do we see? So always start with the chest lead. V1, this is the isoelectric line. So this patient has got ST depression. V2, same ST depression. V3 has got a ST depression. V4, slight, it's okay. V5, V6, a bit ST elevation, right? Let's have a look to lead 1, normal. Lead AVL, ST depression. So almost all the anterior and lateral leads has got a ST depression. Ideally, this side also would have a ST depression, right? Now, we look at the lead 2, 3 AVF. Lead 2, if you see there is a massive ST elevation there. Lead 3, same ST elevation. And lead AVF has ST elevation. Now, that is a massive ST elevation. So if inferior lead has ST elevation, anterior leads will have a ST depression. So that's the reciprocal elevation and depression in MI. All right. So this patient, from the look of the ECG, we know that this is an inferior MI patient. So for this patient, the way that we are going to do the case will be a bit different. Have a look on this one. V1 normal. V2 started to get the ST elevation. V3 ST elevation. V4 ST elevation. V5 ST elevation. V6 ST elevation. Lead 1 ST elevation. Lead 2 ST elevation. But lead AVL ST elevation. Lead 2 normal. Lead 3 normal. Lead AVF normal. So you can get normal or reciprocal depression. So this is a patient who has got extensive MI, right? Because almost all the leads, anterior and lateral, has got ST elevation. So that's an extensive anterior MI or extensive MI. So this is how we know from the stem we can know that this is already a patient who has a acute ST elevated MI, right? So how we do this case will be different from this case. Now coming to another one. This is another case. A 50-year-old male presented to you with a chest pain 30 minutes ago. ECG is given in the next page. You are in the rural hospital. So this is a rural hospital. Nearest tertiary hospital is 4 hours away, and you have no option of transfer at the moment. Take brief history, explain ECG to the examiner, further management to the patient. If we look at this, we see that this is also ST elevated AMI. How we know? So look at the V2 has ST elevation, V3, V4, V5 not much, V6 not much, but they have massive T inversion. Lead 1 has got ST elevation, lead AVL slightly, lead 2, 3, AVF all have bundle branch block pattern. Bundle branch is this kind of M pattern that we see. That's not very important, but you can see definitely this patient has got ST elevation in V2, V3, V4, V5. V5 not much, at least V2, V3, and V4. So septal MI, right? So, but we know that again, do we need to say it's septal MI, it's an extensive MI? No, as long as you can say it is a acute ST elevated myocardial infarction in your diagnosis, you are fine. Okay, so these are the 3 cases that comes in exam, and each case is different. So let's start with the first and second one, and then we will come to the rural hospital. So we are now talking about the tertiary hospital management of MI. So we know the positive points. So patient with acute MI will have acute onset of sudden severe chest pain, crushing in nature, and it can be like pressure, heaviness, constricting, radiating to the neck, jaw, and arm. Associated shortness of breath, nausea, and vomiting can be there, right? So history will be like this. First case, if we look on the first case here, we see that we don't have any ECG in this patient. So we don't know that whether this is a case of pericarditis, is it a normal chest pain, is it a heart attack? We don't know anything about it during our initial stem. So on the initial stem, there is nothing. So for the first case, what we are going to do? Now, ideally, a patient who has crushing chest pain, have a look that's one of the things that we should not forget. Although we don't know the ECG yet, but they have said crushing chest pain. That is enough to think that this might be a case of myocardial infarction or a acute coronary syndrome, because pericarditis is not a crushing pain, right? On that point, what we are going to do is, for this patient, you introduce yourself with the patient and say that I would like to ask vitals from my examiner. You ask the vitals to the examiner. So, dear examiner, is my patient vitally stable for further history? Examiner says stick to your task, or examiner say proceed. What will you do next? You will say, dear examiner, as my patient is having a crushing chest pain, I would like to take my patient to the resuscitation cubicle, attach him to a cardiac monitor, and ask the nurse to do a ECG, secure an IV line, and take blood for necessary investigation, including blood count, inflammatory marker, and a cardiac troponin. What we have done is that we started the process because chest pain is very urgent. While we take the history, these will go on. So any patient crushing chest pain like this, we will take the patient to the resuscitation cubicle, get an ECG, make sure we put an IV line, and draw the bloods. All right. So that's for the first case. And then you go on with your history taking. The second case, where you know they have given a ECG, and ECG shows an acute MI. So from the beginning, you know this is an acute MI. In the second case, how we are going to do this? In the second case, after we say to the examiner that I would like to know the vitals for my patient, we will do this. We will say, given my patient having acute crushing chest pain and the ECG is, you can say that ECG goes with myocardial infarction, okay? Or you can just say that given my patient has crushing chest pain and the ECG is concerning, I would like to take my patient to the resuscitation cubicle, attach him to a cardiac monitor, start him on 300 milligram oral aspirin, secure an IV line, take blood for necessary investigation, including this. If examiner give you vital, and on the vital you find out the saturation is less than 92%, you will start the patient with oxygen. Otherwise, no need. Okay? So at least this much we should do initially. We don't need to start the full monotherapy yet, but we will at least start the aspirin because it's going to save the patient's life. We will secure IV line, take the blood. So we just start the process and then we start asking the question. Make sense, guys? Now, in this second case, when you ask the patient about the pain, patient will say, patient usually will have severe pain. That time you will mention about the painkiller. You will say that you would like to, so I'm going to give you a strong painkiller such as morphine or fentanyl. You can choose either one. So you can give morphine or fentanyl, any of them. Clear? So that's the basic difference between these two cases, how we are doing the case based on what we know. So first case, we don't know the ECG, we just do the basic. We haven't started any aspirin in this patient because we don't know. But second case, we know. So we should start the aspirin and do the rest of it. First case, which does not have any history, any ECG, if we go into the first case again, take history from the patient. They did not say brief history, focused history, nothing like that, just history. For the first one, the history will be same like the chest pain cluster history that we have done, full history. The second case has a ECG there and asked for a brief history. For that case, we don't need to ask a lot of differential diagnosis unless in the task they're asking for a differential, which they will not. So all we need to do in that particular case is asking about the chest pain in detail and focus on the cardiac history only. And we can ask some of the cardiovascular risk factor questions. So in that case, you will ask about the chest pain question in detail. You will ask about the associated shortness of breath, nausea, vomiting, sweating, all of those, right? Racing of the heart. After that, still, if you want, you can ask about any dizziness, lightheadedness, those are fine. But after that, you don't need to ask about respiratory, GIT, anything. Go to the past medical history, SADMA, family history. In the past medical history, we will be focusing on cardiovascular risk. So there are a lot of cardiovascular risk questions we ask. So most importantly, any known medical condition, such as any known heart disease, so known heart condition, any diabetes or high blood sugar, any history of high blood pressure or high cholesterol. Do you do exercise? do you follow a healthy, balanced diet? Do you smoke, drink alcohol? Any family history of heart condition? So that will be your brief history in the second case. Okay, makes sense now? So we need to change cluster-wise things. It's not always we are going to just vomit out the things that we just remember or memorize. It always depends on the case and the task. So right now, I believe you understood about the history of that. The next task is to explain the ECG to the examiner. When we get a ECG, and the task is to explain the ECG to examiner, there is a format that we follow. So you can read the ECG as fast as you can because it will take time if you want to be perfect. So try your best to read the ECG as fast as you can, 15 to 20 second max. And then you start describing the ECG. So say that I would like to describe the 12 lead ECG of my patient, Mr. John, a 55-year-old gentleman, came with sudden onset crushing chest pain. The ECG shows, so on the ECG, first thing we comment is the heart rate, then the rhythm, then we talk about all the different parts of the ECG. So how is the P wave? How is the QRS complex? How is the ST wave? And how is the T wave? So we talk about all of them. So P, QRS complex, ST wave, T wave, ST segment, T wave, and also QT interval. So QT interval is the starting of the Q wave and finishing of the T wave. That's QT interval. So that's what we talk. That's what we say in the ECG explanation. So the best way to talk about the heart rate is knowing how to measure the heart rate quickly. So to check the heart rate, usually in the ECG, they give you a long lead. The long lead is usually the lead 2, where you can see the entire lead. Okay. So in the long lead, you check the heart rate. So heart rate is nothing but, it's easy to remember. So now again, we don't talk about the heart rate. We don't calculate the heart rate if it is irregular. If it is a regular rhythm, then we can easily manage that. So let's say it's a regular rhythm. Regular rhythm means that every RR interval, so this is 1 R, this is 1 R, and then let's say there is another R here. So if the RR interval is equally placed, means that the rhythm is regular. So when we check the heart rate, we check how many large square is there in between two RR interval. Okay, so we can see here, this is 1 R, this is 1 R, and in between these two RR interval, there is 1, 2, 3, 4, 5, 6, 7 large box or large square. So what we do that we divide 300 divided by the 7, which is 42. So it's better to remember the numbers instead of doing the math in exam, such as if there was only one large square in between two hour interval, then heart rate would be 300 divided by 1 means 300. If there was only two large square, then 300 divided by 2 means 150. In the same way, you can just remember the name, the number. So that's what will help a lot. So you just remember that if there is in between two RR interval, if there is only one large square, I know it is 300 heart rate. If there is two large square, I know it's 150. So you just remember that number. instead of doing the math in your head in that time, which will cost more time. Okay, so that's the heart rate, and you only mention the heart rate when the rhythm is regular. In atrial fibrillation, when the heart rhythm is irregular, you don't need to mention the exact rate because it's difficult to measure that in that time. Okay, so we already talked about the normal ECG parts. So we know that this is the P wave, that's the QRS complex, that's the ST wave, that's the T wave. And the QT interval is, this is the Q, so starting of the Q wave and end of the T wave, that's QT interval. So you have a look on here that this is a patient, we can see that the RR interval are regular. If RR interval is regular, means that we can check the heart rate here. So how many large square? 1, 2, 3. And together it's actually 4 large square. So what will be the answer? 300 divided by 4. So that's how we know that this is the heart rate for this patient. Okay, make sense, everyone? So first you comment on the heart rate, then is the rhythm regular or irregular? Then you comment how is the P wave? Is the P wave normal? Normal P wave means it's like this. Sometimes in atrial fibrillation, there will be absence of P wave. Then you comment on QRS complex. Is the QRS complex normal? Is it broad? Is it narrow? So we know that usually a QRS complex should be between 1 to 3 small square. So in a 12 lead ECG, a normal QRS complex is between 1 to 3 small square, not large square. If it is less than 1 small square, that's narrow QRS complex, which we find in SVT patient. If it is more than 3 small square, it is what we call as wide QRS complex. So wide QRS complex, you can get it in VTAC, like ventricular tachycardia. You can also get it in hyperkalemia patient. A lot of cases are there. So you comment on the QRS complex. After QRS, we have the ST way, ST segment. So if there is ST elevation, you mention about the ST elevation or depression. In chest pain case, this is the most important thing that you need to mention. And then you comment whether the T wave is normal or whether the T wave is inverted. And at the end, you comment on the QT interval. A normal QT interval is between 8 to 11 small square. If it is more than 11 small square, that's what we call is prolonged QT syndrome. Okay, so this is how we are going to explain the ECG to the examiner. So what we will do in here, so let's say that when you talk about it, you just say this line. So dear examiner, I would like to describe the 12 lead ECG of my patient, Mr. John, a 55-year-old man, came with a sudden onset crushing chest pain. The ECG shows heart rate of about 75 beat per minute. Now, if heart rate you can't, let's say you can't find out heart rate or you don't know how to calculate it, or you think you are running out of time and you don't want to waste your time by calculating it, just say that heart rate is normal if it looks normal to you. Okay, so it's difficult sometimes to check a heart rate. So if we see here, this is one R and this is another R, right? So if you see 1, 2, 3, 4 large square, that's how we found 75 beat per minute. It's easy if you know. So heart rate 75 per minute, regular rhythm, normal P wave. So we can see the P wave is normal. Normal QRS complex. So QRS is okay. But all we see here is the ST elevation in V2, V3, V4, V5, V6. excuse me, right? And also there is ST elevation in lead 1, lead AVL. We can see ST depression in lead 3. If you, whatever you see, you just mention here. And then we can see that T wave is normal. So you can see that, so T wave is this one, so T wave, we can see the T wave here as well. So T wave is normal, and you can measure the Q wave. So if you see the Q, so this is the starting of Q, and that's the finishing of T wave, right? Sorry, this is where the T wave will be. That's the P wave. So if we see here 1, 2, 3, so this is 15 small square. So QT is a bit prolonged in this patient as well. Okay. So if you see QT prolongation, you mention QT is prolonged. If QT is normal, you just mention QT is normal. Again, if you don't have the time and you don't mention QT where it is not important, you will be fine. For a chest pain case, as long as you mention ST elevation, you will be fine. If you don't find out ST elevation, then they can't pass you. Okay? Does it make sense, everyone, how to explain ECG to the examiner?
Yes, doctor.
Uh,
Thank you.
every points you mentioned, is it in the checklist, or should I
No.
mention only the positive findings?
No, so it's not in the checklist, but yes, you should, if the task is explain ECG to the examiner, that task has a specific mark, so, right? So you will be marked on that particular task. So if you just say the task is not about explain positive findings of the investigation to the examiner. Task is explain the investigation to the examiner, which means you need to use this format and explain all the parts of the investigation, positive and normal. Okay?
Okay, sir.
All right. Now, management. So we have got a patient who has got acute myocardial infarction. So sometimes, depending on how much time we have got, we can explain it longer, we can explain it shorter. So this is a longer explanation. So John, thank you for waiting. Based on the nature of your chest pain, and according to the ECG, most likely you are having an acute myocardial infarction or heart attack. John, I'm very sorry, but it is a serious condition. Heart attack happens when blood flow to the part of the heart gets blocked. Let me draw a picture for your better understanding. So this is our heart. Just like any other part of the body, heart has several blood supply, which carries blood and oxygen to it. It's like heart attack is like a pipe to your garden. If that pipe gets blocked, no water reaches the plant and the plant start to dry out. Similarly, without blood, the heart muscle starts to die and can lead to life-threatening complication. So Aussies love garden related explanation because they love gardening. If you're in Australia, you know gardening is in the blood of Australians. So every Australians usually like they like gardening because they have their yard and all. Some live in a very big property. So they love gardening. They love explanation related to that. So if you can do that, they will be really happy with you. So if you have the time, you can always say in this way, like it's like a pipe to your garden. If that pipe or hose gets blocked, no water comes out, no, the plants start to die. Similarly, without any blood, the part of the heart muscle start to die and it can lead to life-threatening complication. So that's one way to say. If we can give a bit longer explanation. If we are running out of time, we will just say, based on the nature of your pain, you are most likely having a condition called acute myocardial infarction or heart attack. I'm sorry, John, it is a serious condition. Heart attack occurs when blood flow to a part of the heart gets suddenly blocked causing permanent damage to that part of the heart if not treated promptly. So you just say that, definitely draw a picture. So this is your heart. Heart has got blood supply just like any other part of the body. In heart attack, part of this blood flow gets blocked, and because of that, this part which does not get any blood supply start to get permanent damage, and it can cause life-threatening complication if not treated promptly. Okay, so but I love this explanation. If you have time, please try to explain like this. If you can't, just say heart attack means it's a block in the part of your heart. This typically presents as a sudden onset severe crushing chest pain, which can be felt in your arm, neck, and jaw, with associated nausea, vomiting, sweating, and shortness of breath, just like in your case. Why we say these clinical features? Because patient can relate that this is why I am also having all these symptoms. Okay. After that, you need to say something nice and reassuring. Says that please don't get scared. We have one of the best team of cardiologists in this hospital. Now, we don't like you guys to say that, please don't worry, you will be fine. Don't say this kind of line. Say that, please don't get scared. We are here with you, and we have one of the best cardiologists in this hospital. Why we could say that? Because question mentioned this is a tertiary hospital. All tertiary hospital in Australia will have a very good cardiac team. So you're not saying something lie. Moreover, you have come within 12 hours of symptoms. So this is one of the important things, because if patient comes within 12 hours of onset of chest pain, their prognosis is much better, because we can go for the PCI, which is the percutaneous coronary intervention, basically angioplasty. So you have come within 12 hours of symptoms. So with proper intervention, this can be managed very effectively without serious complication. For further management, I will need to admit you to the hospital. I'll discuss this with my senior and also call the cardiologist and a catheter lab who will come and review you. In the meantime, I have already transferred you to the resuscitation cubicle, right? We have already done that initially and taken blood for necessary investigation. If you have given aspirin, you will just mention in here that I have also started you with an aspirin, which is supposed to prevent further clot formation. That was the second case where we already gave aspirin. The first case, we did not give anything. So we'll say now all the monotherapy. So now I'm going to give you a medication called aspirin, 300 milligram tablet to chew, which will prevent further clot formation. I have already started you with IV morphine for the pain, and will repeat until you feel comfortable. That's for, again, the same second case where we started morphine. First case, if you haven't said morphine, you will say this time that I'm going to also give you IV morphine for the pain to make you feel comfortable. The cardiac monitor is showing your oxygen level. If it goes below 92%, I will also start oxygen for you. Even after this, you still have ongoing chest pain, I will start you with a glyceryl trinitrate or nitroglycerin spray under the tongue, which can be repeated 3 times every 5 minutes if needed. So that's what we call monotherapy. So morphine, oxygen, nitrate, aspirin. So that's the immediate management for an acute MI, right? Or acute coronary syndrome. If you have given something, initially just say that I have already given that. If you haven't given anything, just mention all these 4. Once a specialist is here, he might also start you on another blood thinner called clopidogrel and enoxaparin to prevent further clot formation. So we'll give dual antiplatelet, right? So both aspirin and clopidogrel plus another blood thinner, which is heparin or enoxaparin, to prevent further clot formation. The definitive treatment of this condition is to remove the clot and restore the blood flow, which we call percutaneous coronary intervention or thrombolysis. So far, all we have done is the initial management. The definitive treatment is to remove the clot and restore the blood flow, which we call percutaneous coronary intervention or thrombolysis. As you presented within 12 hours, most likely specialist will arrange the PCI, which is the best treatment for your condition. If you have time, then you explain this. In this procedure, a thin tube will be passed through your wrist or groin to reach your heart and find the blocked artery or blocked pipe. Then the specialist may use a small balloon to open it up or place a tiny mesh known as a stent to keep it open. Please don't get scared, as you will be under sleep throughout the procedure and won't feel any pain. So that's what we can, it's better that we explain what is PCI. So a thin tube will be passed through your groin or wrist to reach your heart and find out the blocked artery. And then the specialist may use a small balloon to open it up or place a tiny mesh to keep it open. John, I understand this is overwhelming for you right now, but please know you are in good hand and we will do everything possible to take care of you and manage your condition safely and effectively. Do you have any questions? So that's the management of acute ST elevated AMI. Okay. Now, I want you to see the therapeutic guideline. This is from where we have added everything. So therapeutic guideline also says we only need to give oxygen if saturation is less than 92. In a patient who has acute coronary syndrome, we start aspirin 300 milligram immediately. For ongoing chest pain, if the patient is vitally stable, we can give glycerol trinitrate. For persistent chest pain, we give fentanyl morphine. So that's basically the monotherapy. This is the management.
Sir, if the patient is vitally unstable,
Hmm.
hemodynamic unstable, how I can longer explanation to the patient right that moment?
So usually you will not say anything so initially you will find out patient is unstable. You will take the patient to the resuscitation cubicle. You will start all the necessary management. And what you do that in the physical examination from examiner, you can again ask the vital from the examiner to see if the patient has got stable. That way, you know that you have stabilized the patient. That's
Okay.
done there. But if the patient remains unstable, which is very unlikely to be given in the exam like this, you just need to just to say that we found that your blood pressure was very low and we have taken necessary step to make it stable. So whatever you have given, you just need to say that in the management. But you have to say that, yes, your blood pressure is low. So anything that's unstable that you find, you should mention it during your explanation.
Okay.
Okay, now this is from therapeutic guideline, the management of ST elevated AMI. So any ST elevated AMI, first thing that we need to do is to give aspirin. That's the must. Then we plan the reperfusion therapy. Reperfusion is recommended if patient can come within 12 hours of chest pain. Now, if patient comes within 12 hours of chest pain, the next question we ask, is PCI available within 120 minutes of first medical contact? So don't get confused with this 12 hours and 120 minute. So 12 hours is since the onset of chest pain. So if patient presented within 12 hours, the next question is, can I give PCI or can I arrange PCI for this patient within 2 hours of first medical contact? Okay. So within the first 2 hours of medical contact, if we can arrange a PCI, then yes, we will arrange the PCI for the patient. But if we can't, let's say we are in a rural hospital and the tertiary hospital is 3 hours away, like the third case we are going to discuss. In that case, we can't do the PCI. That case, we will need to choose thrombolytic therapy. And the thrombolytic therapy are those streptokinase, altiplase, retiplase, those ones. Before offering thrombolytic therapy, we always need to make sure that they don't have any contraindication to them. If they don't have contraindication for thrombolytic, we can go for the thrombolytic therapy. And once we make the patient stable with thrombolytics, then we are going to transfer the patient to tertiary hospital. Then sometimes they will have PCI there, but that immediate management you will need to do in that rural hospital. Again, we have got a patient with ST elevated AMI. Aspirin is the first thing. You ask the question, is this patient came within 12 hours of chest pain? Yes. Can I give PCI within 2 hours of medical contact? If yes, then we go for PCI. If no, then we choose thrombolysis if there is no contraindication to it. We also give the dual antiplatelet like ticagrelor, prasugrel, or clopidogrel. And we also give parenteral anticoagulant, which is like your enoxaparin, dalteparin, heparin, those ones. So that's all that's already given in the note, right? So I made the note from here. It is the guideline that we follow in Australia. So all you need to do is to just remember what's written in here. Clear? Any questions about the ST elevated MI management?
Sir, I have a query that we have a one case in rural area where the PCI is not available usually. And in that case, our treatment plan should be thrombolysis. And the important concern in this case, that is the contraindication of for thrombolysis. And in this case, when we take the history, should we take the uh, history which are contraindicated, that is any bleeding manifestation or previous head trauma, should we take during history or should we mention during management?
Okay, good question. Because you already know it's a rural hospital and you can't send the patient to tertiary, so you know that in your mind you know this patient requires thrombolytics. So in your history you will need to ask all those contraindications. Okay, so these are the contraindication that we have to ask in that case. So you'll need to add these questions there. So the contraindications for thrombolytics are this. So absolute contraindication, you will have to ask in the history in that case. So any previous history of bleeding in the brain, any known lesion or any known mass in the brain, especially AV malformation. So you can just ask, do you have any known brain condition? Any known tumor in the brain? Any history of a stroke in the last 3 months? If you suspect this patient can also have an aortic dissection, that based on history. Any active bleeding disorder. So do you have any known bleeding disorder? Any history of head or facial injury in the last 3 months. So these are your contraindications, like absolute contraindications for thrombolytic therapy, which you need to ask in the history in that third case. These are the thrombolytic therapy. We use altiplase, tenecteplase. The parenteral anticoagulation that we use, that's enoxaparin or sometimes unfractionated heparin. Okay, so basically it's very nice and easy. It's all written very clearly in the note. If you please read the note, follow what is written, it is the guideline. So you start with the monotherapy, add the clopidogrel and enoxaparin, and then you talk about the definitive treatment, which is PCI or thrombolysis. Okay, everyone clear about this case? This is the rural hospital case. The history will be same as before, but only thing is rule out any contraindication, which I already mentioned. Explanation same as the last case, but instead of PCI, we will need to say that the definitive, because you will say that the definitive treatment of this condition is percutaneous coronary intervention or thrombolysis. But as we are in a rural hospital and we can't transfer you to a tertiary hospital within 2 hours, it is risky for us to transfer you at the moment without further treatment. So the next most available treatment is thrombolytic therapy, which is a IV medication, which we will consult with a cardiologist and will give you here. Once you become stable, we will arrange transfer to a tertiary hospital where this percutaneous coronary intervention will be done if needed. Okay, that's the only thing you will need to say in that case. So you'll say that these are the two options, but we don't have that option of transferring you at the moment because it's too long. So we're going to go for the thrombolytic therapy. So I'm going to talk to the cardiologist and get the full plan. I have also made sure that you don't have any contraindication to this treatment. So once cardiologist is happy, we will start you with this thrombolytic treatment to dissolve the clot, which is blocking the heart arteries. Once it is done and you are a bit stable, we will arrange transfer to the tertiary hospital where the percutaneous coronary intervention will be arranged with a plan for angiogram within 24 hours, which means that once you go to the tertiary hospital, they will insert a thin tube into your groin, and that tube will go into the heart, find out any blockage there, and if needed, they will put a balloon or a mesh to keep it open. Okay, so that's what's gonna be the plan in this kind of case. Now, if you read our notes, you'll see that I always keep this angina note in the portal, but this doesn't come in exam anymore. So these are just for you to go through. I don't discuss angina in the course because I haven't seen an angina case for a long time. Usually pericarditis and the chest and the acute MI is the main case under this cluster. Okay. Sometimes CVS risk assessment comes in exam. So in a CVS risk assessment case, the case is something like this. So you are a GP, a middle-aged man comes to have a consult after his brother went for coronary bypass 2 weeks ago. He is obese, no other past medical history. So you've got a middle-aged man coming to you because his brother had a coronary artery bypass. Your task is focus history, physical exam, explain what will be the initial management. So in the history, we follow what we call A, B, C, D, E, F, S. That's how we assess the cardiac risk of a patient. So first of all, you go in, introduce yourself with the patient, and always say that, I'm sorry to hear about your brother. How is your brother doing? So do not miss these kind of tiny things because you know from the history that his brother had a coronary bypass. You should definitely ask that how is your brother doing? After that, patient will say he's all right now. So you will say that I know you, so John, I know something is you're here to consult about something today. Can I know what's bothering you? Or can I know what you want? Like, can I know how I can help you today? So patient will say, Doc, I just want to make sure that I don't end up like my brother. So I want to know what I can do to prevent something like this. So you'll definitely appreciate the patient. Say, I really appreciate that you are coming here to discuss about it. I'm going to ask you some questions to find out the risk that you might have, and then we can make a plan. Okay, so then you will start asking questions. So first of all, before asking the A, B, C, D, E, F, S, you can first ask about whether the patient has currently got any symptom. So you can say, how are you doing these days? Do you have any chest pain? Do you get short of breath on exertion? Do you feel quite tired and fatigued? All right, so that's the first thing, symptom questions. Patient will say no. Then you can go into the ABCD AFS. So you can ask one by one. So how is your diet? So do you follow a healthy balanced diet? Do you do exercise? Any history of high blood pressure or high cholesterol? Any history of diabetes or high blood sugar? Do you smoke? Do you drink alcohol? Apart from your brother, is there any other family history of any heart condition? Do you do any work? Is there any stress at your work? How is home? Any stress at home? Any other past medical condition? Do you take any regular medication? So it's very nice and easy history taking. Okay, that's all that we really need to do. Physical examination from examiner, usually not much, but start with the general appearance. Ask for any sign of high cholesterol, such as genital asthma, xanthoma, or corneal arcus. Pickled same, any pallor, any cyanosis, any edema. Ask the vitals, but in here BMI is important because obesity is a risk factor. Do a quick cardiovascular exam, respiratory exam, and ask for office test, mainly blood sugar and ECG. Also, you can say, dear examiner, I would like to know if there is any cardiovascular risk chart available. The cardiovascular risk chart looks like this. They don't give that in exam, so you just ask. So you will not get the cardiovascular risk chart from the examiner. So you will say that from history and examination, I have found some of the risk factors, such as you have high blood pressure, your body weight is more than ideal, you have diabetes or blood sugar issues, and your diet is also not healthy balanced. Also, you have been smoking for 20 years. All of this can put you on some risk of having heart related complication in the future. Okay, so what you have done, that now it's not everyone will have all these risk factor. Whatever risk factor you get there, you just mention them. Then you say that please do not get scared. We can prevent this complication by adopting healthy lifestyle. So I would advise you to cut down your alcohol to the safe level. Try to maintain an ideal body weight. So make sure you have a healthy, balanced diet. I can arrange a dietitian for you who you can talk and understand how to have a healthy diet. Try to do some exercise, ideally 30 minutes most of the days of the week. If you want, I can also arrange an exercise physiologist for you who can show you some cardiac exercise. Try to avoid a stressful situation. Take some break if you feel overly stressed. And definitely cut down your smoking. If you would like to do that, please make another appointment. I will I will I will talk to you in detail about how we can help you to stop smoking. Also, I need to arrange some investigations for you, such as blood count, your kidney function, do an ECG to rule out any baseline abnormality, checking your blood sugar and cholesterol level. Once I get all of this, then I will arrange. So, what we do nowadays in Australia, we arrange a healthy heart check. So, I will arrange a healthy heart check for you, and I will put all this, your cholesterol, your age, sex, blood pressure, everything in a chart, which we call cardiovascular risk assessment chart. And with that chart, we'll be able to know how much risk of heart condition you will have in the next 5 years. Based on that, if we need to do anything, if we need to add any medications for you, we will do that in that session. But please start the lifestyle changes and please get this blood test done and we will go from there. Give some reading materials. So say, I will give you some reading materials about how to do cardiac exercise, and I'll also give you some balanced diet fact sheet. Okay. So that's all that you need to talk in here. It's all about talking and talking, but it comes in exam sometimes. So you just need to know how to do this kind of case in exam. All good, everyone? So that's basically all about our tonight's session. So I hope you guys enjoyed the class. I hope it is making sense a lot. So I hope you are liking how we're taking the session. But important thing to take home is how just a single history format can help you to do a few cases. And you don't need to memorize every case differently. All you need to know is the management of each case, and other part is just in a format. It becomes very smart and concise way to do this kind of cases. So as you know that you have few more sessions with us as part of the trial class, and you are doing our classes of the course already because course has started now. So once the free 2 week session is over, we will start the course classes just like to have a regular flow. But if any of you still haven't joined the course, you want to know about the course, you can definitely ask any questions if you want. Okay. Otherwise, you can also go to our website. So if you just write, I'll show you how to go there. So if you just write firstaidamc.com.au, you'll go into our website. In our website, you'll see the 5 months clinical course, and all the information that you need to know about the course is here. This is a 5 months course that we offer for clinical students, and course has got everything that you need to pass the exam. And it will be more than enough for anyone. If you can finish everything that we are going to show you, you will be fine. You can pass the exam in your first attempt, just like any other students who have passed from here. Also, to give you a bit of an idea about the course, this is a video that you can have a look. So let's just share this video with you.
Welcome to First Aid AMC, your trusted pathway to success in the AMC exams. Admissions are open now, and this is your opportunity to join one of Australia's most successful AMC preparation programs. We offer comprehensive training for AMC MCQ and AMC Clinical, designed to give you structure, clarity, and confidence. With a proven 99% success rate, our system has helped thousands of international doctors begin their careers in Australia. Visit firstaidamc.com.au or contact us today to start your journey.
All right, this is just like a short video that we normally create for students who wants to know a bit about the first aid clinical course, but there is a lot to know about the course. You can always go into our website and read about it. Any questions, anything that you want to know, you can always ask in these free sessions. You don't need to take subscription of the therapeutic guideline. If anything is relevant, we will add it in your slides. These slides are only available for our course students. Okay. All right, guys. So that's it for tonight. You have your next class with us. So let me have a look. When is your next class?
Sorry, doctor.
Yes.
What is the root of enoxaparin in the acute MI?
So same thing, it's just going to prevent any further clot formation. So all of these are going to just make sure that no further clot is formed.
So should we give it, should we give it subcutaneous or intravenous?
Usually subcutaneous enoxaparin, and if we want to give intravenous, that will be unfractionated heparin.
So I'm talking enoxaparin, only subcutaneous.
Yes.
Okay.
So it does not dissolve the clot. So none of the things that we give in the initial management, it can dissolve the clot. The only thing that can dissolve the clot is that PCI or the thrombolytic medication. All of these that we are giving, aspirin, clopidogrel, or the parenteral anticoagulant, that's just make sure that there is no further clot formation happens. Okay. So I was just going to say that so your next class, another thing that enoxaparin is not only subcut, you can give IV as well if we want. Okay, so any of those will be fine. It's not only subcut. Now, your next class is on 17th of January. So 17th of January we have, so this is Wednesday, 17th is Saturday. So Saturday you will have a random role play session like before, but there will be a new mentor who is going to do that with you. And then followed by that, on 18th and 21st, you have 2 more cardiac class, and that will be all the free 2-week sessions. Okay. That's it for tonight, guys. Thanks for joining us. Have a good night. See you soon. Bye.